Welcome to AETCM, the emergency medicine channel. Today we are going to discuss about a case of cellulitis. A 50-year-old female presented to here with complaints of the right lower limb pain with limb swelling, sir. On arrival, regarding the at triage, the vitals were all stable, so we are going ahead with the secondary survey, sir. A patient, a 50-year-old female with a known case of type 2 diabetes mellitus with a CAD history, came to the ER with complaints of right lower limb which had been there for the last 2 days, sir. The pain was associated with swelling and reddish discoloration of the skin, erythematous presentation. Apart from that, there is a past recurrent history with the same episode of cellulitis in the limb yearly twice for the last 2 years, sir. Going ahead with the investigation. Examination.
With this history, what are your differential diagnoses?
Initially, with this kind of history of fever, limb swelling and pain, we need to consider about the soft tissue infections. Based upon the layer of the skin involved, we can differentiate whether it to be cellulitis, erysipelas or a skin abscess. Considering about the clinic, if you take into account of the other clinical factors and other, then we can either see whether it can be progressing into toxic shock syndrome or necrotizing fasciitis. We can.
All that is complications.
Yes, sir.
Here you have a acute onset of
Fever
with the unilateral lymphedema and redness of the skin.
Yes, sir.
That is your presenting complaints, right?
Yes, sir.
With that, as you told, superficial skin infections is one of your DD.
Yes, sir.
Erysipelas or cellulitis being the topmost. What other conditions will you suspect?
Regarding the infective and non-infective, we can consider.
Okay.
We can consider to be a unilateral DVT superimposed with an infection if there is a past history.
It can be unilateral DVT. Do you want a superimposed infection in case of a acute DVT to have fever?
No, there can be there will be the warmth can be there, but fever, systemic symptom of fever cannot be there in a DVT.
Will thrombosis cause fever? Thrombosis can present like fever. So acute CVA patients, acute MA patients can have increase in rise body temperature. So thrombus in the body itself can present like fever. So that is one thing. What else? If a patient is having DVT and patient is having fever, what else? What complication of DVT can present like fever? Present as fever?
Complication of DVT like infection.
Where?
The lower limb, where because of the DVT venous plexus, because of the venous insufficiency, the pooling of blood will be there and infection.
Infection where?
Lower limb.
Superficial veins.
Superficial. Okay.
Okay. It's a thrombophlebitis. Yes. Thrombophlebitis can form usually in the deep veins, but the deep venous thrombus can extend to superficial veins through the perforators. Once superficial veins are thrombosed, it can cause phlebitis features in the lower limb, which can have infective worsening. So fever can be due to that part also. Yes. Fine. So you have now superficial skin infection, DVT. Yes. Anything else?
Sir, like suppose not specific to this case, but if you say any superficial infections, skin infections, erythema migrans like in Lyme's disease, any insect bite after the...
Insect bites, correct. It can be a foreign body bite, foreign organism bite. It can very well be a snake
animal bite and even insect bite.
Yeah, it can be a rat bite, it can be a snake bite, isn't it? So bites, animal or insect bites can be there. What else?
Normal like herpes zoster.
In Kerala, especially
filariasis.
Filariasis. It can be filariasis. Very unlikely to have a acute fever associated with this thing. But if the patient is coming from a filarial belt, you need to suspect filariasis too. You can't rule it out.
Yes.
Okay. So these are the major differential diagnoses that you are going to suspect, right? But what about if patient is having similar complaints but involving a joint?
Septic arthritis.
septic arthritis is a possibility, isn't it?
Depending on the location, we can, if suppose there is a orthopedic operation done, there's a graft placed, post which on the surface of that graft there's infection, we can consider to be a graft induced infection.
So it can be an infection due to a hospital procedure, or can be due to infective pathology of the joints, like septic arthritis, trauma causing hemorrhage into the joint, which get infected. Septic arthritis. What else?
Osteomyelitis. I mean, that all are like complications.
Can be chronic, right? Yes, it won't be like it won't be like only erythema, lymphedema, and fever. There will be a sinus which is producing pus also. But what about if the pain and swelling and fever is pain, erythema, and swelling is mainly over the ankle joint or on the metatarsal joint?
Gout.
Gout. Can be gout.
Non-infective, like we can take off gout, even contact dermatitis, wherever it is contacted, that area will be erythematous, and pruritus would be an additional feature there. But
yeah, so we have infective causes, vascular causes, inflammatory causes, and arthritic causes. These are the most common headings in which we can classify the conditions and then evaluate. So from history, we know this much, that it comes either one of these. Now comes examination part. Go.
In examination part, we could see an erythematous rash extending from below the knee to the ankle joint, sir. And the...
Involving ankle joint or not?
Not involving the ankle joint.
Okay, so now we can rule out
gout.
Arthritis part. Arthritis part is ruled out. Now it is skin versus subcutaneous layers or the deeper layers is the question now. What else?
Next, other component was like there is no any pus on palpation.
Sinuses.
No sinuses.
Sinuses secreting pus. Osteomyelitis is ruled out.
And next on palpation, there is no tenderness. On palpation, there is no tenderness. Next, there is a raise in temperature as compared to the other limb, and there is no increase in diameter at the calf as compared to the other limb.
Okay.
That are the specific examinations.
Okay. So if there was a increase in diameter in comparison to the other limb, what will you suspect?
First thing, we need to in emergency. First, we need to consider DVT as the.
Okay.
Second, the compartment syndrome is to be the.
Something is increasing the girth of the limb. Most probably it is edema. Isn't it?
Yes.
So a significant edema, anything that produces significant unilateral edema will increase the girth of the limb. Need not be compartment syndrome as such. As you told, it can be DVT. It can be a patient who is having cellulitis with a systemic fluid overload state. A CLD patient with a cellulitis definitely is going to have much more better girth than the other limb.
Yes.
But bilateral will be the involvement. Or else it can be, as you told, infection involving deeper layers, like you told up to dermis is what we are suspecting in cellulitis, right? You have erysipelas.
Erysipelas is the dermis. Epidermis is erysipelas. Dermis and subcutaneous tissue is the cellulitis. Anything below is the skin abscess. Usually, if it is a prurulent thing.
Abscess or what if the infection is affecting the fascia?
Necrotizing fasciitis.
So fasciitis, it can be necrotizing or non-necrotizing, but fasciitis, and if it affects the entire fascia and comes below, deeper, it affects the muscles also.
Yes, sir.
So muscles getting edematous can have compartment syndrome. So girth of the limb is important here, but the importance is for monitoring. Like a single value that left limb is bigger than the right limb is not going to tell you what you are dealing with. It just means that there is edema. But if it is increasing in girth, maybe 2 hourly or 3rd hourly, if it is increasing in girth, you know that ongoing condition, rapidly progressive, has to suspect compartment syndrome. Okay. And you told one more thing, right? Non-tender. If there was tenderness, what will you suspect?
DVT is considered.
DVT. All DVTs have tenderness.
Acute phase has
Acute phase has tenderness. Once clot becomes stable, there won't be any tenderness in DVT. So clot stabilization is usually within
6 to, like the clot formation and blocking of the vessel.
That is there.
24.
When do you say a clot is stable? After 72 hours.
Okay.
Once 72 hours is over, you say that clot is a stable clot. That is why we don't go for any acute thrombolytic events after 72 hours. Okay. So with after 72 hours, if you palpate, there won't be any tenderness. But otherwise also, when you're palpating, patient is having tenderness, or when you're doing passive movements, patient is having tenderness, what will you suspect?
Compartment syndrome.
So if you are having a tenderness along with the passive movement tenderness, you are suspecting compartment syndrome, and the tenderness will be disproportionate to the pressure you give or the movements you do. But if patient is having tenderness, significant tenderness, but the range of movements is not involved as such, what will you suspect?
Bone fracture or
bone fracture, true, but bone fracture is something that history usually will not miss, right? But yeah, bone fracture you can suspect. What else?
if it is a dermatome kind of thing, herpes zoster.
Herpes zoster, possible, but that okay, fine. Dermatomal involvement herpes zoster can be there. What else?
Tenderness.
Necrotizing fasciitis, necrotizing fasciitis. Since fascia is involved, there will be tenderness present. Okay, yes. So wherever the erythema is there, you palpate there, patient is having tenderness, you should suspect deep lying infection, isn't it? Okay, so these are the examination findings that you will do. Yes. What else?
Sir, next with the investigatory, like now once we did the examination, next going with the investigation, we sent for a total count to see if there is any systemic signs of any infection. By leukocytosis, CRP, ESR increased, will give it.
That will be there in local infection also, right?
Cellulitis, we divide it into mild, moderate and severe. Okay. Mild would be only seeing that there is a swelling and erythematitis with no systemic signs of any infection. But clinically already patient has systemic signs of infection of showing of fever. So we can consider it to be a moderate or severe category. Depending upon the lab results, we further labs and also clinical symptoms like shock, hypertension would consider it to be severe cellulitis. But here there is no signs of any hypotension, tachycardia. So it's a moderate kind of cellulitis.
Okay, fine. So basically you are saying whether the infection is localized or whether it has spread over the blood, right?
Yes.
Fine.
So went ahead with the infective count. CRP was 150, sir. WBC count was 12,000, sir. Neutrophil predominance of 85%.
150.
Sir, CRP
150. Yeah.
WBC 11,500.
Okay.
And so neutrophil predominance was there.
Okay. So acute infection, actually bacterial infection are suspected.
Yes, sir. Like regarding the other she was diagnosed to be pre-diabetic, even HbA1c was around 6, sir.
Okay.
Apart from that, now coming with the antibiotics for such patient.
Okay, so investigation wise, you have done a CBC, CRP just to confirm your infective pathology. Do you want to send any other investigations here?
Ideally, if you want to rule out DVT, D-dimer would be a specific test.
Okay.
But in case of infection, again, it will be elevated. So,
yeah. So, D-dimer, will it confirm DVT?
It will prove that there is no DVT. Most
so, it's a negative predictor. D-dimer is negative, you can say there is no D-dimer, DVT. But if D-dimer becomes positive, you really can't rule it out. And D-dimer is a acute phase reactant. So in acute severe inflammatory conditions, D-dimer will be elevated. So do you want a D-dimer here?
No, not in this.
Okay. But if you are suspecting DVT, how can you rule out DVT in this patient?
In this patient, ideally ultrasound, going ahead with an ultrasound venous Doppler would be the best way.
Ultrasound, doing a venous Doppler to rule out DVT is the best way. But what is the primary thing as an emergency physician you can do?
We can check for, we should not be
Is there any risk score for DVT?
No, the history-wise, there is no any risk factors.
History-wise, what is the risk score for DVT? Well score and PERC rule, right? You have a well score and a PERC rule. These are the risk assessing factors for DVT. So you can see this patient. If this patient doesn't fulfill Wells criteria or a PERC rule, then DVT is an unlikely scenario. But in major cellulitis, especially ascending cellulitis, with the significant disproportionate limb sizes, you should suspect DVT. And you have to confirm, you have to do venous Doppler. Okay. So, you can do a DVT risk score analysis using PERC and well score, and if present or significant limb disparity is there, you can go for a venous Doppler. So that is another investigation you will do. Anything else?
Also, radiological investigation is justified if you are considering it to be a skin abscess, and MRA could be done if you are considering it to be like at this point of time, if you are considering radiological things to be.
So MRI is only indicated if you have a previous history of trauma, which you are suspecting to be non-healed, or a trauma which is post-trauma got infected, chronic symptoms with sinus presentation. You can go for MRI. But with the acute case, MRI is not at all indicated as such. What else? Any other investigations you want to do here? Any other investigations you want to do here?
Venous, like to see saphenous veins and perforators, and that all doesn't.
But you are just going to prove there is varicosity. No, acute varicosity means varicosity proving in this condition is
actually venous insufficiency will be a predisposing factor for recurrent cellulitis.
Recurrent cellulitis. But with that history, you can.
That's
get.
yes, sir.
Anything else?
Lab parameter or some.
No, lab parameter is also fine.
Nothing.
Here you told venous insufficiency also. Initially itself we told if the patient is coming from a filarial endemic region, we need to suspect filariasis. So when you ask the patient coming from filarial region, if you are suspecting acute filariasis, you can rule out lymph node enlargements with lymphangitis versus DVT. So you are doing venous Doppler, you can ask them to check for lymphatic channels causing congestion, lymph node dilations and lymphangitis. So that if you are doing the ultrasound, you can rule out. That is only when the patient is coming from filarial prone areas. Like we had such a patient around last 5 days back, right? One of the staff that presented with phlebitis like features with erythema, severe tenderness over the, you guys were not there. Okay. So the patient presented with a upper limb, but edema, erythema over the upper limb vein with severe tenderness on touch. So we had a small doubt whether it is lymphangitis versus this thing. So we can do the ultrasound to rule it out. So investigations. So in this patient, you told her here CBC is elevated, CRP is 150, there is cellulitis. So there is a moderate cellulitis present. So will you send a blood culture in this patient?
Ideally, cellulitis, this kind of things coming in blood is very less percentage. If there is any pus secreting or that has a more prominence of, or if there is any abscess, do an IND and check the swab, that has more prominence. If there is any signs of shock or if the patient is mostly going to sepsis, then only there is a clear-cut indication to send blood culture. Otherwise, it does not help. Mostly it will be negative.
So unless patient is in organ failure, do not send unnecessary blood investigation because it's a superficial skin infection.
Localized infection.
Not going to yield any blood culture reports as such. Correct. So blood culture is not indicated. Now, how will you proceed with cellulitis, this patient?
Sir, first we need to see whether the patient requires hospitalization or not.
Correct.
Regarding hospitalization, we consider hospitalization in case of sepsis who are having toxic shock syndrome like features, or if there is a necrotizing fasciitis that is rapid growing of the cellulitis area within 24 to 48 hours.
So how will you know it is rapidly increasing?
With history and history, we should not wait for any radiological. If there is any history indicating it's rapidly growing, we have to go for a surgical management rather than waiting for radiological proof. Like,
for example, your patient is having cellulitis in the lower leg, right?
Yes, sir.
Think of a condition that on presentation patients till middle 1/3 of the lower leg. Okay.
Demarcating line was.
Yeah. So you can
mark the demarcating line and then see within the few hours whether it's
any
progressing.
patient who presents to ER, if the affected area doesn't have skin peeling or blebs, it will be difficult to rule out necrotizing fasciitis from cellulitis in the early phases, right?
Yes, sir.
because we can say necrotizing fasciitis is more tenderness than cellulitis. There will be muscle tenderness will be there and all we can say, but patient's pressure, pain response and all is patient to patient varying. We can't depend on that. So one of the things we can do is necrotizing fasciitis is a rapidly expanding infection because it's a deep infection, not superficial infection. So you can put a demarcating line. You find the upper part of the cellulitis line and demarcate it with a clear marker pen, non-erasable marker pen, and recheck the patient in 3 to 6 hours and see whether it is crossing over the demarcation. If it is crossing over, it's an ascending infection. Necrotizing fasciitis should be suspected. So that is
this
one thing
requires hospitalization. Even if the cellulitis is over the joint, that also requires hospitalization.
Correct.
And if there is already a graft or above any like iatrogenic kind causes and where the cellulitis, that requires admission. And if you feel on examination there is crepitus, then you have to suspect gas gangrene and that requires admission.
Correct. So if you suspect crepitus, the diagnosis will change from cellulitis to necrotizing fasciitis. Gas gangrene is always necrotizing fasciitis. There is no cellulitis in necrotizing fasciitis. What are the most common organisms causing necrotizing? Cellulitis.
Cellulitis is group B streptococcus is the most common.
Streptococcus is the most common. What is the second most common?
Staph. But whenever staph is there, it will be purulent. So there we should suspect there any abscess or complications immediately. We need to be suspecting it can go into osteomyelitis or mostly.
Yeah. So basically it's group B streptococcus or staphylococcus. Basically gram-positive organisms is what you expect in a acute cellulitis. So your coverage should also include antibiotics for gram-positive coverage. Will you suspect gram-negative organisms in acute cellulitis? No. What about, in what kind of patients will you suspect gram-negative organism in cellulitis?
First thing, if it is immunocompromised.
Correct.
And multiple hospital admission kind of a patient.
Okay.
And next, specifically is necrotizing fasciitis can be because of gram-negative.
Correct.
And human bite, animal bite, they're supposed to be gram-negative bacteria.
Trauma secondary to bites.
Bite.
Okay. Because anaerobic organisms are there in the saliva, right? Yes. Okay, what else?
Suppose CLD, like a high risk proportion, we can consider if CLD patient developing cellulitis, they
compromised
that all comes under immunocompromised.
But the thing is, cellulitis secondary to a non-healing ulcer. So there can be patients who present with cellulitis with minimal scratch injuries. In that case, you are not suspecting. But think about a patient who is having chronic venous insufficiency, venous ulceration, chronic non-healing ulcer. That ulcer is there. Okay. Yes. Now there is cellulitis above the ulcer. So cellulitis is acute with chronic non-healing venous ulcer on the down. There you need to suspect gram-negative organism because that ongoing non-healing ulcer can harbor gram-negative organisms, even though cellulitis is most common. So any chronic ulcerations or abscesses in the area, you need to suspect gram-negative. On top of what you told, frequent hospital administration for the same recurrent cellulitis or immunocompromised patients, these patients you need to suspect gram-negative. Okay. So what are the most common organisms causing gas gangrene?
Clostridium.
Clostridium species perfringens. Okay. Now coming to this, your treatment comes, right? Yes, so your question now will be, as an emergency physician, does everyone requires admission or not? Will you admit everyone?
No.
No need. So mild and moderate cellulitis can be managed as a OPD basis, in which severe cellulitis or toxic cellulitis or systemic involvement only requires IV antibiotics and admission. Now, think about mild to moderate cellulitis. What is the first line drug that you will give before disposing the patient to home?
Augmentin plus clavulanic acid as the antibiotic.
So basically gram-positive coverage. So gram-positive coverage is now divided into two sections.
MRSA, MSSA.
MRSA and MSSA. Will you suspect MRSA?
In India right now, as there is no community spread, our definitions of MRSA will be different.
Yes, so MRSA, if you are suspecting, there should be healthcare associated organism.
history of
Suspicion
colonization.
of organism should be from healthcare. Community acquired MRSA is not there in India as of now, which is reported as well, is not there. It's skin infection. So you really don't want to start your vancomycin, linezolid for a cellulitis patient. What you need is a good MSSA, methicillin sensitive antibiotic coverage. That is your
Flucloxacin.
basically non-augmented penicillins is what you need. Most commonly available penicillin with MSSA coverage is augmented. Flucloxacin is a IV preparation. You can't send the patient with IV preparation. So if you are sending the patient home, it is amoxicillin or augmentin is what you are, amoxicillin clavulanic acid or amoxicillin is what you are going to send the patient home with. Or else first generation cephalosporins we can give, cephalexin and all you can give and send the patients as tab form. Okay, so you give the course for 5 days and ask the patient to review if at all lesion is worsening or patient is developing systemic complications, right?
Yes.
Right. That is when you are sending the patient home. So what else? This is antibiotic coverage. What else will you give to the patient? It's not only antibiotics, right?
Like apart from the antibiotic, one pain medication, depending
You
upon the
need
pain.
to give some pain medication. Ideally,
we prefer to go with PC. Anti-inflammatory is
Anti-inflammatory.
but moderate and severe cellulitis, we don't advise anti-inflammatories because it reduces the signs of the inflammation, and we don't know whether the patient is going to necrotizing fasciitis or not.
correct.
It is avoided right now.
Correct. More than that, if it is necrotizing fasciitis and all, muscle injury can always strain the kidneys. NSAIDs is going to cause more problems. But in mild cases, a non-inflammatory drug, NSAID drug will improve the pain. You can give paracetamol also, acetaminophen also for pain as well as fever, and antibiotic. What else will you ask the patient to do?
First thing would be the limb elevation so that the edema should reduce. That is when the infection can reduce.
Yes, so 10 to 20 degree limb elevation can be given. Ask the patient to be done. What else?
Same reason.
Bags of dressings can be given, isn't it, to decrease edema. Will you ask the patient to take a full bed rest?
No.
No, you should not ask the patient to take bed rest because already there is localized cellulitis, venous stasis. You don't want a DVT complication too. So you ask the patient to take care of his normal activities. Don't strain the limb, but normal walking and taking traveling can be done. So that is discharge time. So what if this patient requires admission? What will you give then?
In admission, same, we can go with injection of augmentin 1.2 gram. We can start with the baseline. And apart from that, flucloxacin is the drug of choice if for parenteral.
Okay, for MSSA, current drug of choice is flucloxacin.
MRSA vancomycin.
Yeah, flucloxacin, what is the dosage?
We give 1 gram Q 6 hourly.
1 gram 6 hourly you give for 5 to 7 days you give, isn't it? But unfortunately, it's not available in tablet form. So when you are discharging, you have to convert it to ampicillin or augmentin.
When we start with parenteral, if the patient is responding, then within 2 days we can change to oral and discharge.
Correct. Step down therapy. When will you give gram negative? The earlier conditions that we told. What is the preferable gram negative antibiotic? Preferable gram negative antibiotic. Fluoroquinolones or cephalosporins are the preferred gram negative antibiotics that you want to give.
Along with that gram negative, I think another atypical would be so clindamycin would be the.
That is the extra thing you need to give. So if you are suspecting necrotizing fasciitis or a aggressive variant of cellulitis with a gram negative coverage, you would prefer a gram negative coverage, that is third generation cephalosporins or a second generation cephalosporins along with the or with the fluoroquinolone, but along with clindamycin, because clindamycin has toxin stabilizing effect. Toxin stabilizing effect actually helps in gram positive organisms also. Gram positive, especially Staph aureus, has toxin releasing property, so it will stabilize the toxin production and improvement of the patient. But it should be also started from gram-negative organism. Will you get a surgical opinion for incision and exploration or a
IND.
surgical debridement of acute cellulitis patient?
If there is it's considered to be purulent cellulitis, then IND would be the best choice.
Yeah, so underlying abscess
Abscess
is
or
there,
sinus
you need
anything.
to relieve the abscess. If no underlying abscess,
Then
if it is
medical.
just simple cellulitis, do you want a surgical involvement?
Like if it's rapidly growing, like
Yeah, so
necrotizing.
surgical debridement is only indicated in a necrotizing fasciitis patient. Unless you are suspecting necrotizing fasciitis, you really don't want a surgical involvement for the patient. But it's better to keep the patient in surgical loop, because if at all it worsens to be a necrotizing fasciitis, the surgeon can take the patient up for emergency debridement, which will help us in source control, isn't it? Okay. Anything else is there?
Regarding if we are considering to discuss about MRSA, then vancomycin is the drug of the choice right now, or with linezolid it can be used. And regarding penicillin allergy kind of cases, then trimethoprim sulfamethoxazole is the other alternative for oral medication.
In case penicillin G is allergic, right?
Penicillin is allergic. Other thing, considering to be doxycycline, these kind of antibiotics have developed strep and staph have developed resistance in community, so we don't prefer giving only doxycycline. And in case of recurrent cellulitis in the same limb, the importance in the treatment part would be post the treatment of the acute phase of the cellulitis. There would be the venous insufficiency causing this recurrent cellulitis, so we need to give a compressive stockings in non-infective period, so that there will be less amount of edematous and it will be less prone for the
Skin damage.
Apart from that, if you are considering patient is having irrespective of it recurrent cellulitis, then we can go with a prophylaxis kind of a regimen. Right now in India we use a Pentits, that is the oral penicillin V, which we give 400 mg BD for a few months, and after 4 to 6 months we stop, and if there is again another episode of cellulitis, again we continue with the treatment of acute phase and followed by the prophylaxis. Alternative to that would be macrolides like azithromycin, but they are not significantly resistant. If there's penicillin allergy, we can go to azithromycin kind of things, but they are not. They're usually resistant to staph and strep.
Okay. Anything else, sir?
Yes.
Covered, right?
Okay.